Shifas starting.
Yeah, we are going online. We are going live. Good afternoon, everyone. I am very happy to invite all of you to the 11th episode of Nitte Anaesthesia Education Series. We started in last August, and this is the month of June 2022, and this is 11th in the series, and it is running successfully due to the contribution of all my colleagues, our friends all across the country who have contributed academically as well as otherwise, and the students who were very active participants, not only as the viewers but also as the participants in each program. It was a wonderful journey for this 11th episode, up to this 11th episode. This time we are going to discuss about chronic renal failure and kidney transplant. We have a very interesting faculty today from Bengaluru and other places. Dr. Narendra Babu, Dr. Geeta, Dr. Ravi, Dr. Joylin, and we have students from Amrita Institute of Medical Sciences, Cochin, Dr. Begum, Dr. Varshini. I welcome everyone, our faculty, the resource persons, my colleagues, the students, everyone. I again heartily welcome everyone. And now I call upon my colleague, Senior Professor Dr. Gayatri Bhatt, who is the coordinator of our skill lab and medical simulation center. She has vast experience in teaching as well as organizing various events. She is a very resourceful person, to say the least, in every aspect, whether it's patient management, whether it's teaching, whether it's training the students, or organizing various events, not only related to academics, even otherwise. I request Dr. Gayatri Bhatt to welcome and introduce today's faculty for everybody's benefit. Welcome to you, madam, as well. Over to you.
Good afternoon, everybody. It gives me immense pleasure to invite all of you, welcome all of you. And I would say during COVID situation, all our hidden talents and potentials have come out. Similarly, during that time, around in August 2021, as the webinar was going on, virtual discussions were on trending, our HOD, we always say he is a pioneer in so many things. And he's what to say, he is ready to open-minded and he's ready to experiment. Similarly, all of us also support him because we like the enthusiasm in him. He wants students to learn in any possible way, from morning 8 o'clock or 7 o'clock till night. I think his mobile is not at all switched off. So with that introduction, today we will be coming to the 11th Nitte University Department of Anesthesiology and Critical Care is organizing Nitte Anaesthesia Education Series. It's called NAES. It is 11th program today. And today will be that the most relevant disease. See, as we are giving anesthesia, or whether it is for the major surgeries or incidental surgeries, or even a small monitored anesthesia care, every time we have to be careful about the renal parameters. And today, as we had the series, last series, we have discussed all these things. Today, it will be transplant. And just before this, we were discussing with Geeta and Ravi sir that transplant is there in all the institutions now. Even the government has supported, and many of the government institutions have the transplant units. So with that background, I feel it is most relevant that what we are discussing today. Today, we happen to be having the most doyens of anesthesia, the faculty, they are most experienced, but not senior or too much aged like me, like who are in the last few, like what to say, 3 to 4 years of the last fag end of their career. So we have young and dynamic professor and HOD of Devraj RS Medical College, Dr. Ravi Madhusudana. He is very active, not only in his academic career, he is, has many, what to say, laurels to put in his credit, like scientific committee chairman and treasurer for KISACON, Karnataka State. I remember how nicely he has invited us and looked after. The hospitality was great during organizing chairman of PGXL 2022. He has more than 90 publications in Index Journal, and he has given guest lectures, zonal conferences, PGXL, ISACON, and all that. So welcome to Ravi, most dynamic HOD of Kolar. And we also have Narendra Babu MC. He is MBBS from KIMS Bangalore, MDDA from JJMC Davangere, and he is professor and HOD of institutional affiliations of KIMS Bangalore. And his areas of interest happen to be obstetric anesthesia. And we have none other than Geeta Sia. As Shripad was telling, we have very active, interested professor and HOD of anesthesiology and critical care in MS Ramaya Medical College and Hospital. Actually, I am feeling little more proud or to introduce her, as she was my student also. And that time I was just an assistant professor at SR. We used to enjoy doing duties together. I'm sure some of the days she will remember. We used to sit in Vijay ICU and chat and chat and chat. Yes, Geeta? That time I was,
sure, madam. It's
yeah.
always so nice to be, I mean, I'm really proud to say this is my moment of joy to be introduced by you.
Yeah.
And, thank you so much for the kind words.
From those days, it's not only the academic, she was very active. And when she was on duty, we used to be really relaxed. And she has diploma in not only anesthesia, DA or DNB, she has multifaceted interest, like she's PG diploma in hospital and healthcare management. She has done it through IGNOU, and she has essentials of palliative care. That is Indian Association of Palliative Care, which always happens to be a sister concern of anesthesia. Many people are interested in pain relief these days, and she has one of the certificate course in that also. And see, that is palliative care. And exactly opposite to that is emergency care, where she is HA certified ACLS and BLS instructor. There you have to act immediately, emergency. Where palliative care is you cool down, treat the patient, and be very patient with the patient party. She also has international trauma life support instructor course. She is a guest speaker in many conferences, and she has publications, more than 30 in national and international journal, and a special interest. I remember in AOA, when we were in Delhi, she gave such nice talk, and some of the original, what she had done research in obstetric anesthesia, some of the epidural, she had her own data, and she had her own experience. It was very impressive that day. That day again, I felt she is my student, though it was not so much like that. It was almost like a friend colleague she was. And she has interest in IDA, also difficult airway, she's a life member. And recent one simulation, she is one of the member. Yeah, and I will be failing in my duty if I don't introduce Joylyn Stephanie D'Souza, one of our own junior colleague. She did her MBBS and MD in St. John's, and she is happily married to a neurologist who has done DM and neuro, and he is also working with her. She is academically very interested with the life membership of ISA, IDA, and she is a teaching faculty of in our simulation center also. So without taking much of your time, I'll hand over it to the discussion of today's academic event, renal transplant and anesthesia for the concerns and the issues in the renal transplant. Thank you very much.
Now I invite Dr. Narendra Babu, Professor and Head of the Department of KIMS Bangalore, to render the master class on pathophysiology of kidney failure. Over to you, Dr. Narendra Babu. Thank you.
Good afternoon. At the outset, I would like to thank Dr. Sripad Mehendale and his team from Shema Institute of Technology, Nitte Groups of Education for providing me an opportunity on this august audience. I thank the organizers once again. Today, my topic is Pathophysiology of Chronic Renal Failure. I, Dr. Narendra Babu, Professor and Head of the Department, Anaesthesiology, Kempegowda Institute of Medical Sciences. In the next 40 minutes, I will be trying to briefly outline the pathophysiology regarding chronic renal failure. The complications of chronic kidney disease or chronic renal failure presents the anesthetist with a number of clinical challenges related in part to altered drug handling and to difficulties with vascular access and fluid balance. Safe anesthetic management requires an understanding of chronic renal disease or chronic kidney disease pathophysiology to prevent aggravation of pre-existing disease. The idea of this topic is to understand the pathophysiology, so as anesthesiologists, it will be better for us to manage the cases. Coming back to the definition, what is the definition? Chronic kidney disease is defined as the presence of kidney damage or an estimated glomerular filtration rate less than 60 ml per minute per 1.73 square meters, persisting for 3 months or more, irrespective of the cause. It is a state of progressive loss of kidney function, ultimately resulting in the need for renal replacement therapy like dialysis or transplantation. The 2012 KDIGO classifies CKD into 6 categories based on glomerular filtration rate, G1 to G5, with G3 split into 3A and 3B. It also includes the staging based on 3 levels of albuminuria, A1, A2, and A3, with each stage of CKD being subcategorized according to the urine albumin creatinine ratio in milligram per gram percentage or milligram per millimole, which is estimated in the early morning spot urine sample. The categories include GFR of 90 ml per minute per 1.73 square meter and above normal. The second is mild disease with GFR of 60 to 89 ml. Moderate is between G3 is further classified into 3A and 3B, which is moderate. GFR is around 45 to 59 in 3A, and it will be 30 to 44 ml per minute per 1.73 square meters in 3GB. G4 is severe, wherein the estimated GFR will be between 15 to 29 ml per minute, and the last end-stage renal disorder, ESRD, commonly known as end-stage renal disease, where the GFR will be less than 15 ml. The 3 levels of albuminuria include an albumin creatinine ratio called as ACR. A1 is ACR less than 30 milligrams per gram. ACR2 is 30 to 299 milligrams per gram, and A3 is ACR greater than 300 milligram per gram, or otherwise 34 milligrams per millimole. This small graph represents the staging. Stage 1, kidney damage with normal or increased GFR. Stage 2, as I've earlier explained, deposits the same thing. End-stage renal disease is stage 5. The common etiologies, major causes of chronic renal failure or chronic kidney disease include diabetes. Diabetes type 2 is more common with the percentage being around 30% and compared to diabetes type 1. Hypertension is around 24%, glomerular nephritis is 17%, polycystic kidney amounts to 4%, with chronic pyelonephritis being 5%, and unknown causes leading on to the majority compared to diabetes and hypertension is 20%. Some of the toxins which are identified are gonadin, methylgonadin, phenols, tyrosine, and aliphatic amides. CKD may result from disease process in any of the three categories. Like AKI, CKD can also be classified. The pre-renal, interstitial renal, and post-renal. Pre-renal, decreased renal perfusion pressure. Intrinsic pathology includes the pathology of the glomeruli, the tubules, interstitium, or the vessels. And post-renal is obstructive. What is pre-renal causes? Chronic pre-renal disease occurs in patients with chronic heart failure or cirrhosis with persistently decreased renal perfusion, which increases the propensity for multiple episodes of intrinsic kidney injury, such as acute tubular necrosis. This leads to progressive loss of renal function. The causes of pre-renal are hypertensive nephrosclerosis, atherosclerotics like renal artery stenosis, atherosembolic diseases like cholesterol embolies. Next, the most common chronic is intrinsic renal vascular diseases. The most common chronic renal vascular disease is nephrosclerosis, which causes due to the damage to blood vessels, glomeruli, and the tubule or interstitium. Coming to the interstitial glomerular disease, it can be either nephritic or nephrotic. A nephritic pattern is abnormal urine microscopy with red blood cell cast and dysmorphic red blood cells, occasionally includes white blood cells, and a variable degree of proteinuria. The most common causes of nephritic pattern is post-streptococcal glomerular nephritis, infective endocarditis, shunt nephritis, and good pasture syndrome. And the nephrotic pattern is associated with proteinuria, usually in the nephrotic stage. The albuminuria will be greater than 3.5 grams for 24 hours. It is commonly caused by minimal change disease, focal segmental glomerular sclerosis, membranous proliferative glomerular nephritis like type 1 and type 2, and diabetic nephropathy and amyloidosis. The tubular and interstitial intrinsic disorder includes the tubulointerstitial disease. The most common is autosomal dominant polycystic kidney disease. Other etiologies include nephrocalcinosis, most often due to hypercalcemia or hypercalciuria, sarcoidosis, Sjögren's syndrome, reflex nephropathy in children and adults. There is an increased recognition of the relatively high prevalence of CKD of unknown cause in Central America and parts of South Asia called as Mesoamerican nephropathy. The glomerular disease includes diabetic nephropathy, primary glomerular diseases, as I've already told, and the tubulointerstitial. The most commonest is the autosomal dominant polycystic kidney disease. And some secondary to autoimmune disease includes the Sjögren's syndrome and sarcoidosis. The commonest pharmacology involved is non-steroidal anti-inflammatory nephropathy. Vesico-uretral reflex is common in young adults and in children. The post-renal causes can be due to prostatic disease, enlargement of prostate, nephrolithiasis, or abdominopelvic tumor with mass effects on the ureters. Retroperitoneal fibrosis is a rare cause of chronic ureteral obstruction. The benign prostatic hyperplasia, commonly seen in males of older age, urethral stricture, kidney stones commonly seen nowadays, and pelvic mass. Coming to epidemiology, prevalence approximately 10% worldwide, and in India it is slightly more, 8 to 16%. Highest prevalence we see in Taiwan, Japan, and United States. Mortality is approximately 66% after 5 years on dialysis. Male preponderance is seen. Race ethnicity also has a epidemiological incidence of CKD. Highest rate in people of African descent, potentially due to their mutations in APL1 which is associated with increased risk of early onset disease. Hispanics have an increased rate compared to the non-Hispanics. The true incidence and prevalence of CKD are difficult to determine because of the asymptomatic nature of the early to moderate CKD. The prevalence of CKD is around 10 to 14% in general population. Similarly, albuminuria, microalbuminuria, which was referred earlier, is no more the term is used. GFR less than 60 ml per minute, and prevalence amounts to around 7% in such patients. KDOQI, otherwise called as Kidney Disease Outcome Quality Initiative, mandates that for labeling of chronicity and CKD patients should be tested on 3 occasions over 3 months period. 2 of the 3 results being consistently positive will say patient is having a CKD. Natural history and progression of CKD, commonly general population, is called as community CKD. Nephrology practices where they are called as referred CKDs. Community CKDs is seen in older population. These individuals have a lifelong exposures to cardiovascular risk factors like hypertension and diabetes, which can affect the kidneys. The average rate of decline in the GFR in this population is around 0.75 to 1 ml per minute per year after the age of 45 to 50 years. When compared to referred CKD, presents at an early age, because which may be due to the autosomal dominant polycystic kidney or acquired nephropathies like glomerular nephritis, diabetic nephropathy, and tubo-interstitial diseases causing renal damages, in which the increase in GFR can be around 10 ml per minute per year. So what are there are certain modifiable risk factors, the modifiable and non-modifiable risk factors. The non-modifiable risk factors include older age, male, gender, and non-Caucasian ethnicity, which includes African Americans, Afro-Caribbean individuals, Hispanics, and Asians. In Asians, South Asians, and Pacific Asians, all adversely affect CKD progression. Genetic factors which affect CKD progression have been found in different kidney diseases. Single nucleotide polymorphisms of genes coding for mediators or renal scarring and renal angiotensin aldosterone activating system are found to influence CKD progression. These are non-modifiable causes or risk factors. Coming to modifiable risk factors, this includes systemic hypertension, proteinuria, and metabolic factors. In systemic hypertension is one of the main causes, along with in United States, second only to diabetes. Then systolic rather than diastolic BP seems to be predictive of CKD progression. Obesity and smoking have been related to the development of CKD. Also, metabolic factors such as insulin resistance, dyslipidemia, and hyperuricemia have been implicated in the development and progression of CKD. Recommendations for CKD screening. Screening mostly targeting high-risk individuals in being implemented worldwide. The guidelines recommended screening high-risk population include patients long-standing hypertension, diabetes mellitus, and population aged over 65 years. These include a urine analysis, a urine albumin creatinine ratio, otherwise known as ACR, or a protein creatinine ratio called as PCR, and estimation of GFR preferably by chronic kidney disease epidemiology collaboration equation, which is now the equation employed in rating the GFR. It is the most effective approach, cost effective, and there is no evidence to justify screening asymptomatic individuals. The pathogenesis amounts to simple. When 50% of the nephrons are lost, CKD progresses regardless of the etiology. And when the number of nephrons are decreased, this is a logarithm showing how the CKD progresses. When the nephrons are reduced, irrespective more than 50%, there is adaptive hyperfiltration of the glomerulus, which in turn causes increased glomerular permeability, which leads to an increase in renin-angiotensin aldosterone system, leading on to increased filtration, which causes proteinuria, which in turn leads to dyslipidemia. And increased filtration of proteins and macromolecules may lead on to nephrotoxic inflammation and remodeling, leading on to tubulointerstitial fibrosis, which leads to decreased GFR, decreased urine output, and systemic complications. Some pathogenesis involved with the leading cause of CKD, I will be trying to brief them out. The first and foremost is hypertension. In hypertension, there are certain glomerular and vascular changes. In this, elevated systemic blood pressure causes a hypertrophic response, leading to intimal thickening. The mechanism are compensatory at first, but later lead to glomerular damage, causing global sclerosis or focal segmental sclerosis. Next, it is the interstitial nephritis. The vascular and glomerular disease leads to tubular atrophy and intense chronic interstitial nephritis. This leads to chronic interstitial nephritis, thought to be secondary to immunologic process against ischemic mediated antigen changes on the tubular epithelial surface. Chronically, these changes lead on to tubular and glomerular loss of nephrons. With the death of some nephrons, less available to maintain GFR, gradual decline in GFR is noticed as the nephrons continues to die. In the next commonest is diabetes, wherein diabetic nephropathy is the most commonest. The hyperglycemia is the culprit here. So chronic hyperglycemia, the flowchart depicts the pathophysiology behind diabetic nephropathy. In chronic hyperglycemia are thought to be the primary cause. Unlike other tissues of the body, transmembrane glucose transports, otherwise called as GLUT receptors, do not facilitate intracellular glucose transport in the kidneys. This effect is mediated via a number of mechanisms like glomerular hyperfiltration, direct effects of hyperglycemia, advanced glycosylation end products, otherwise called as age, and cytokine secretion. What happens when glomerular hyperfiltration is there? Glomerular hyperfiltration is mediated mainly via dilatation of the afferent arterioles, which leads to an increased GFR. This dilatation of the afferent arterioles is mediated by number of mechanisms in diabetic nephropathy. The most common is hyperglycemia, high insulin-like growth factor concentrations, which are both hypothesized to cause this increased glomerular hyperfiltration. Hyperfiltration of glucose leads to augmented sodium glucose transport in the proximal convoluted tubule, causing enhanced sodium transport. Because expansion, which leads to expansion of blood volumes and a rise in GFR. Hyperglycemia and age. Hyperglycemia and age directly induce mesangial matrix production, cellular expansion, and apoptosis. The two have been shown to increase basement membrane permeability to albumin. Coming to cytokines, cytokines have elevation in vascular endothelial growth factors, transforming growth factor beta and profibrotic proteins increases damage to nephrons at different levels. Specific mechanisms in this are very unclear due to cytokines. Coming to glomerular nephritis, glomerular injury takes place via inflammatory as well as non-inflammatory mechanisms. Non-inflammatory mechanisms include the segment syndrome. Change includes nephrotic syndrome, which causes focus segmental glomerular sclerosis and membranous nephropathy. A dramatic rise is seen in glomerular permeability. Several cytokines here also play a major role, especially interleukin I3 and complement system also plays a mechanism C3, C5b and 9, which causes the thickening of the glomerular basement. This induces glomerular sclerosis, which can be global or focal. Coming to inflammatory injuries, common examples include post-streptococcal glomerular nephritis, membranoproliferative glomerular nephritis, and Collins perfura. This inflammatory injury is mediated via different mechanisms. Some members of the complement system, here C5a is the culprit. This cells produces oxidants and proteoses that cause fibrin deposit and capillary damage fibrin deposition, which causes capillary wall damage and produce proteinuria. Unlike podocyte targeting in non-inflammatory injuries, disorders in which glomerular endothelial and mesangial cells are principally involved to exhibit a more dramatic response to immune injury. Unlike in acute kidney injury, where the healing process is complete with complete functional kidney recovery, in chronic and sustained insults from chronic and progressive nephropathies lead on to fibrosis and destruction of the normal architecture of the kidney. This affects all the three compartments of the kidney, like the glomerulus, the tubules, and the interstitium. The sequence of events which leads to scarring and fibrosis are complex and they overlap one another, which causes infiltration of damaged kidneys with extrinsic inflammatory cells. There is activation, proliferation of loss of intrinsic renal cells, which can happen through apoptosis, necrosis, mesangiolisis, and podocytopenia. The extracellular matrix commonly seen in cases of diabetics, which causes increased cells of myofibroblasts and fibroblasts. This deposition of extracellular matrix replaces the normal architecture. The mechanisms which are involved in the acceleration and progression of CKD or chronic renal failure are systemic and intraglomerular hypertension, which leads on to glomerular hypertrophy, intrarenal precipitation of calcium phosphate, altered prostanoid metabolism. All this causes focal segmental glomerulosclerosis. Clinical risk factors for accelerated progress are proteinuria, hypertension, the races like black race, and hyperglycemia, exposure to lead, smoking, metabolic syndromes, and some analgesics, commonly the NSAIDs, and obesity have been linked to the progression of CKD. Patients with stages 1 to 3, that is more than 30 ml per minute per 1.73 square meter, are generally asymptomatic. Water and electrolyte imbalances or endocrine or metabolic derangements are not clinically evident. These disturbances manifest clinically in stages 4 and 5. Glomerular GFR less than 30 ml per minute. Now coming into the signs and symptoms and the mechanisms involved are, you can see generalized edema, which causes swelling. This can be due to water retention, due to loss of GFR. Water and fluid moves into the extracellular space, which increases hydrostatic pressure, causing pitting edema. There can be pulmonary crackles. Fluid accumulation causes pulmonary edema and loss of airspace, causing ventilation perfusion mismatch. Anemia, erythropoietin, which is secreted by the kidneys, and reduction of kidney cell masses causes decrease in erythropoietin. This is the main cause in renal failure for anemia. Weight loss can be due to protein energy, malnutrition, which can be due to chronic metabolic acidosis. Hyperkalemia, commonly seen in presents as malaise and palpitations. Inability of the kidneys to secrete potassium in the urine leads to life-threatening arrhythmias. Hyperphosphatemia, normal inability of the kidneys to excrete phosphate. It can also be due to high parathyroid hormone secretion. Hypocalcemia, once again, which can be due to secondary to low vitamin D3 levels. In the later stages of CKD, low levels of hypothesized due to decreased synthesis of 1-alpha-hydroxylase enzyme, which converts calcifidiol to calcitrol in the kidneys. Secondary and tertiary hyperthyroidism, commonly seen to compensate for low calcium and low vitamin D levels. The parathyroid gland increases the parathyroid hormone secretions. This leads to a high bone turnover, always attempting to normalize the low calcium blood level. This can lead on to extraosseous calcification. Parathyroid hyperplasia causes secondary hyperparathyroidism. Secondary and tertiary parahyperthyroidism are also seen. When it comes to GI complications, ecchymosis or GI bleeding, increased tendency to bleed due to uremia-induced platelet dysfunction. There can be precardial rub or pericardial effusion, which can present as chest pain or malaise, uremic carditis. Coming into the pathophysiology and its complication, chronic kidney disease can be caused by a multitude of underlying conditions. Once half the total nephrons are lost, progress similarly regardless of etiology. Underlying etiology include decreased total number of nephrons, as I've earlier explained, which increases the glomerular filtration, which in turn increases the filtration of the proteins which are lost in the urine, producing proteinuria. And this causes an increase in renin-angiotensin aldosterone system, and there are certain cytokine release which causes and increased growth factors. These changes lead to adaptive hyperfiltration, which may lead on to GFR may actually increase during the time. This occurs when GFR is increased, it is a compensatory mechanism. Later on leads to intraglomerular capillary pressure, which causes glomerular hypertension. And this increased pressure, glomerular hypertension and intraglomerular capillary pressure and inflammatory mediators are said to cause damage to the remaining nephrons. I have tried to put it very simple in this flow chart, which is when there is a decreased number of nephrons, there is an initiation, which is an initiation factor like diabetes, hypertension, exposure to toxins and immune complex. This can lead on to this decreased number, leads on to accelerated sclerosis of remaining nephrons, increases the intraglomerular pressure, and this can cause structural and functional changes of surviving nephrons. This is the simplest pathogenesis that can be put in cases of chronic kidney diseases. In hypertension, there is fluid and sodium retention. And once there is fluid and sodium, there is also increased RAA system activities, renin-angiotensin aldosterone activities, which causes an increased sympathetic nervous system activity. This causes vasoconstriction. Also, vasoconstriction can be due to an increased calcium, which may be due to secondary hyperparathyroidism. And there are certain impaired vasomediator, active mediators, when there is a decreased nitric oxide, which causes endothelium-mediated vasodilatation. Pathogenesis of secondary hyperparathyroidism, also known as mineral and bone diseases in CKD. There is decreased GFR, which causes the inability to excrete phosphate, and this causes an increased serum phosphate, which leads on to an increased fibroblast growth factor. FGF23 is increased. It is a regulatory mechanism. When there is an increased fibroblast growth factor, there is decrease in potassium phosphate reabsorption, and the phosphate excretion is increased. Eventually, the increase in serum phosphate concentration overwhelms the fibroblast growth factor, and this causes increased parathyroid hormone secretion, which is secondary to hyperparathyroidism. Fibroblast growth factor 23 also inhibits 1-alpha hydroxylase. 1-alpha hydroxylase is used in conversion of 25-hydroxyvitamin into 125 hydroxy D, which is otherwise called as calcitrol. This decreased calcitrol is due to decreased GI calcium absorption and decreased serum calcium, and this may once again causes increased parathyroid hormones. What happens to these consequences? This decreased GFR causes decreased urinary phosphorus excretion, which increases the phosphorus to maintain normal serum calcium concentration. And there is an increase in the FGF23, which causes inhibition of 1-alpha hydroxylase, which causes the decrease in calcitrol, leading on to interstitial calcium absorption, which increases the parathyroid hormones. This is the basis of secondary pathogenesis in secondary hyperparathyroidism. There is always chronic anemia in kidney diseases. Why? One is decreased erythropoietin production. The other one is production of RBCs are decreased due to the decreased red cell mass. And the third component is the lifespan of the RBCs per se are decreased due to chronic metabolic acidosis. And the hemoglobin level, which are supposed to be defined here, is less than 13 grams in men and post-menopausal women, less than 12 grams in pre-menopausal women. The anesthetic implications with the changes in pathophysiology, the most important is fluid and electrolyte derangement. Why there is fluid and electrolyte derangement? Especially sodium. In normal individuals, more than 25 millimoles of sodium ions are filtered daily, with 1% of them being excreted. Only 1% of them are excreted. CRF can be associated with sodium retention, and it can have a sodium depletion or normal sodium balance, and influenced by factors such as diuretic use and cardiac function. Most patients demonstrate a mild degree of sodium and water retention, whilst the extracellular fluid volume remains isotonic. Ironically, the patient with CRF also have impaired renal concentrating mechanisms, and thus extrarenal fluid losses such as vomiting, diarrhea, or pyrexia may rapidly cause hypolemia. Potassium and magnesium. Potassium is the most important electrolytes in chronic renal failure. Adaptive process increase potassium secretion in the distal nephrons and also in the gut. There is wide range of variation of potassium concentrations depending on the factors such as diuretic use. It tends to be elevated. Acute changes presents a lot of life-threatening sequences. A range of drugs also increases the potassium in CKDs. The common drugs are beta blockers, potassium sparing diuretics, ACE inhibitors, angiotensin antagonists, NSAIDs, and nephrotoxins such as aminoglycosides and cyclosporins. Extracellular acidosis causes an exchange of intracellular potassium for extracellular hydrogen ions in an attempt to maintain electrical neutrality. So coming to acute acidosis, the serum potassium level raises by 0.5 millimole for each 0.1 unit decrease in the pH. You have to know this, 0.5 to 0.6 millimole per liter for each 0.1 unit decrease in pH. The reason can be hypercarbia has to be avoided in general anesthesia. And next, magnesium. Magnesium is handled by the kidneys much like potassium. Reduced excretion may cause hypermagnesemia, which causes muscle weakness and potentiate the effects of non-depolarizing muscle relaxants. And coming to acidosis, chronic metabolic acidosis is a feature of end-stage renal disease. The inability to secrete protons and buffers, example phosphate, or to regenerate bicarbonate limits the clearance of hydrogen ions. Furthermore, there is reduction in glutamine utilization, which reduces ammonia production and secretion into the proximal tubule. And retention of organic ions causes a progressive increase in anion gap, and there is further fall in the bicarbonate concentration. Plasma bicarbonate concentrations rarely fall below 12 to 15 millimoles per liter. There is little reserve in these patients to counter acute acidosis caused by ketoacidosis or sepsis. The calcium phosphate parathormone and renal osteodystrophy. This flowchart depicts what exactly happens when a chronic renal failure. When there is nephron destruction, there is decreased phosphate excretion, which causes metastatic calcium deposits and may cause hyperparathyroidism. Once there is decreased phosphate excretion, there is decreased vitamin D3 production, which causes decreased interstitial calcium absorption. Once again, there is hypocalcemia, causing on to hyperparathyroidism. I have been repeatedly explaining this pathophysiology because as anesthesiologists, this all play a major role when we are managing a patient with CKD. Hematological abnormalities, a normochromic normocytic anemia is common finding. Decreased renal erythropoietin, parenchymal erythropoietin production is the main cause, which may be due to uremic toxins or the red cell masses. As earlier explained, red cell life is decreased or the renal mass is decreased. So all this compensate for an anemic condition in these patients. There is also dietary deficiency in iron and folate. Ferritin can be as low as 200 nanograms per ml. Synthetic erythropoietin has revolutionized the treatment in anemia. A rapid hemoglobin concentration above 10 grams also worsens hypertension, which may precipitate heart failure. Compensatory mechanisms in CKD normally shift the 2,3-diphosphoglycerate to the right, thereby the oxyhemoglobin curve is always to the left, and this is the compensatory mechanism which helps in chronic anemic patients in CKD. Coming to coagulopathy, patients with CRF have a tendency to bleed excessively during perioperative. Standard tests like prothrombin, activated partial thromboplastin, inter-INR, and platelet count may be within normal limits. But here, platelet activity is deranged. This is called as uremic thrombocytopathy or thromboasthenia, wherein there is decreased adhesiveness and aggregation. This may be caused also due to the release of von Willebrand factor or factor VIII complex, which binds to and activates platelets. Increased platelet release of beta thromboglobulin and vascular production of PGI2 also contribute to coagulopathy. Coming to cardiopulmonary abnormalities, cardiovascular abnormalities are common, which can lead to 48% deaths in these patients. Systemic hypertension can be due to pressure overload or volume overload. Volume overload can be due to fluid and sodium retention. Pressure overload can be due to atherosclerotic changes, and these are more common in polycystic kidney diseases. Some patients may require beta blockers, ACE inhibitors, ARB inhibitors, alpha antagonists, and vasodilators to control their blood pressure adequately. And alteration in the control of renin, angiotensin, aldosterone contribute to hypertension in 30% of the patients. Ischemic IHD is the next frequent mortality causes in CRF, normally occurs over the age of 45 years. This may be due to accelerated atherosclerosis because there is always a decreased plasma. Hyperlipidemia is seen in cases. Dyslipidemia or hyperlipidemia is common in CKD patients. And the valves are also calcified. Aortic calcification is the most common stenosis compared to mitral valve calcification. This is due to the elevation in the calcium phosphate product and parathyroid hormone concentrations. As a result, bacterial endocarditis are more common in these patients, and also they may be more common due to diuresis. Hemorrhagic uremia causes pericarditis and pericardial rub. Uncommon and occurs in patients receiving inadequate dialysis. If untreated, may rarely progress to pericardial tamponade with hypertension, elevated jugular venous pressure, and signs of failing cardiac output. Pericardiectomy may be required, and these are reserved for those who fail to improve with immediate dialysis. Post-operative complications with pulmonary system are very common, may be due to pulmonary edema, malnutrition, anemia, impaired humoral and cellular mechanisms, which may lead on to atelectasis as well as pulmonary edema. Immune function, sepsis is the leading cause of death in CRF. This may be due to the inhibition of cell-mediated immunity and humoral defense mechanisms. There is an increased production of pro-inflammatory cytokines. Superficial infections are commonly seen in fistula and catheter sites. The incidence of viral hepatitis B is decreased after the introduction of erythropoietin and hepatitis B vaccination. The hepatitis C infection is also common with hemodialyzed patients. Hospital staff must take precautions against these blood-borne viruses in these patients. Coming to the gastrointestinal abnormalities. Gastrointestinal abnormalities are frequent with anorexia, nausea, vomiting, contributing to malnutrition. Urea is the mucosal irritant, which may lead on to bleeding. Gastric emptying is delayed in these patients. Residual volume is increased, pH is lowered. Peptic ulcer is the most common, and proton pump inhibitors is commonly used in these patients. And the use of rapid sequence induction intubation techniques needs to be balanced against the risk of difficult intubation in chronically ill and patients with poor definition. Succinylcholine will increase the plasma potassium concentration approximately by 0.5 millimole per liter. Patients with diabetes mellitus have an influence on difficult intubation and autonomic gastric paresis. In practice, patients with CKD, whatever may be the etiology, are for rapid sequence induction and intubation. Neurological abnormalities are common, especially the central and peripheral system are involved. The central spectrum, for example, includes mild personality alterations to asterexis, myoclonus, encephalopathy, and convulsions are seen. Peripheral neuropathy is commonly seen with low and stalking sensory loss. Both dialysis and renal transplantation may improve the neuropathy. The peripheral neuropathy presence should alert an anesthetist to the presence of autonomic neuropathy with delayed gastric emptying, postural hypertension, and silent MI. The response to anesthesia will be exaggerated whether it is for GA or for regional techniques. There are two types of neurological disturbances which are unique with CKD. One is dialysis dementia, presents with dyspraxia, myoclonus, and dementia. This is related to aluminum toxicity in patients on chronic dialysis. The other one is dialysis disequilibrium syndrome with rapid initial reduction in plasma urea concentration at the start of dialysis. Now the endocrine disturbances, as I have already explained, hyperparathyroidism is commonly seen, which may affect the parathyroid function and lipid clearance. Glucose tolerance is also impaired due to reduced requirement, and there is reduced requirement for exogenous insulin in diabetic patients with CKD, probably due to reduced metabolism of insulin by the failing kidney. Patients with CRF have abnormalities of temperature regulation with reduced basal metabolic rate and a tendency to hypothermia. So you have to be careful, and monitoring also includes the monitoring of the fever or temperature. Temperature monitoring is one of the most important things. There are certain pharmacokinetic changes, little beyond my pathophysiology, but this is the physiology plays an important role in the pharmacokinetic changes. Hypoalbuminemia and acidosis increase free drug availability. So benzodiazepine and thiopentone doses should be reduced to 30 to 50%. Propofol are unchanged. Metabolites lack sedative activities. The volume of distribution changes, and mental state means that reduction in the dose. There is blood-brain barrier is decreased also in chronic CKD patients. So when propofol is used, the dose should be used with caution. Highly ionized lipid-soluble drugs is partially or completely dependent on renal excretion. Duration of action of a single dose will depend on the redistribution rather than excretion. Most lipid-soluble analgesics are metabolized in the liver. The sum of the metabolites are far greater activity than the parent compound, especially morphine, with the metabolite morphine-6 glucuronide. Fentanyl undergoes hepatic metabolism. Fentanyl is supposed to be the safest drug in cases of CKD. The elimination of volatile anesthetics, you have to be, because some of them are metabolized, especially with the earlier generation, methoxyflurane, the newer generation, sevoflurane and isoflurane. They produce theoretically nephrotoxic fluoride ions. So when the sevoflurane is being used under low flow anesthetic techniques, the duration of anesthesia is an important criteria. At low flow, as the usage of sevoflurane increases, the fluoride ions are released more. Atracurium, atracurium are the best choices as they don't depend on any drug for any organ for metabolism or excretion. The anticholinesterase and anticholinergic drugs are also prolonged. Local anesthetics are valuable agents for perioperative pain control, but the duration of action is reduced. Doses should be reduced by 25% because of the reduced protein binding capacity, because most of the local anesthetics are bound to albumin. Coming to my last and final slide, this is what the pathophysiology of kidney. In a nutshell, if you can understand this particular slide, most of the patients you can handle easily. The first, the lighter shade depicts the functions. What are the functions? Sodium balance, potassium excretion, acid excretion, calcium and phosphate balance, and erythropoiesis. In CKD, what happens to these individual functions? Sodium retention and volume overload is there. Hyperkalemia is there. Acid excretion is impaired. Metabolic acidosis. There is increased phosphate, increased parathyroid hormone, leading on to decreased calcium and calcitriol. And in erythropoiesis, anemia can cause. So how do you treat them as anesthesiologists? Sodium restrictions, use of diuretics, dietary restrictions, and use of anesthetic drugs carefully, especially succinylcholine. Avoid NSAIDs in post-operative analgesia. Sodium bicarbonate in chronic acidosis is given to keep it at 23. And phosphate binders and calcium mimetics are used to treat calcium phosphate and calcium phosphate balance. And erythropoietin is created a new generation. Erythropoietin stimulating agents are used along with iron replacement. In a nutshell, this is the pathophysiology and the problems and the treatment associated with chronic renal failure. The take-home points is the incidence of chronic renal failure is increasing. Significant pathological changes affects most of the organs. Patients with CRF are amongst the most challenging of the hospital population. Ischemic heart disease is often silent, even in patients who are diabetic. The perioperative mortality and morbidity with these patients are very, very high. With this, I conclude my talk. I once again thank Dr. Sripad Mehendale and his team for providing me in this Nitte Anaesthesia Education Series. Thank you. Thank you once again. Any questions? I will take it later. Thank you.
Thank you, Dr. Narendra Babu.
Thank you, Dr. Narendra Babu, for this wonderful session on chronic renal failure.
So a little louder, we can't hear you.
Thank you, Dr. Narendra Babu, for this wonderful session. I hope you can hear me.
Yes, sir, can hear you now.
Yeah. Any questions? Audience can also may there unmute and ask questions if there are any. Okay, if there are no questions, we may proceed to next session. That is a discussion on a patient with a chronic renal failure appearing for kidney transplant. Over to Dr. Suma.
Thank you, Dr. Narendra Babu, for the excellent presentation. Now we move on to the case discussion. End-stage renal disease posted for renal transplant. I welcome the moderators, Dr. Geeta CR and Dr. Charlene D'Souza, and the postgraduates from Amrita Institute of Medical Sciences, Kochi, Dr. Varshini and Dr. Beegam. Over to you, Varshini and Beegam.
Yes, ma'am.
And the moderators.
Just 1 minute. Good afternoon, everyone. I'd like to thank Dr. Shripada, Dr. Sumalata, and Dr. Gayatri and all the organizers. And without much ado, I think we will continue with this. I'll just put this on full screen.
Full screen down, ma'am.
Yeah, but that I'm not able to go on to that. 1 minute. 1 minute now. I'm sorry about this. Girls, can you share if you have it with you?
Yes, ma'am.
Okay.
Yeah.
I'll stop sharing. 1 minute.
You share the presentation.
Yes, ma'am.
Okay.
I think now you may share your screen and make it to full screen, Dr. Varshini, and yeah. Yes.
Good afternoon. Chronic kidney disease for renal transplant surgery. My patient is 32-year-old male, teacher by profession, non-case of chronic kidney disease, stage 5, now admitted as prospective renal transplant recipient. History of presenting illness. Patient was apparently normal till March 2021 when he presented to emergency department with complaints of pedal edema and acute onset palpitations. There was no history of chest pain, giddiness, or syncope at that time. Pedal edema was bilateral, which was gradually progressive, extending up to ankle. There was no associated pain or diurnal variation. And routine lab investigation was suggestive of severe renal failure, and BP was high at that time. So he was started on renal protective measures and antihypertensives. Subsequently, on regular follow-up, his serum creatinine showed to increase as high as 10.9 milligram per deciliter. And on May 2021, he was admitted with progressive worsening of pedal edema, and creatinine at that time was around 13.08 milligram per deciliter. He underwent an emergency hemodialysis via IJC catheter, and left radiocephalic AV fistula was created under local anesthesia. Hemodialysis was continued as twice weekly, and 6 weeks later, hemodialysis was initiated through left radiocephalic AV fistula, and IJC catheter was removed. After 3 months, frequency of hemodialysis was increased to thrice weekly basis. Now he's having bilateral swelling of lower limb, no facial puffiness, no history of chest pain, palpitation, breathlessness or cough, no history of seizures, loss of memory or behavioral changes, no history of nausea, vomiting, diarrhea, constipation or abdominal distension. There is no history of abrupt increase or decrease in weight. He was put on transplant workup, and his brother was found to be a match and is currently admitted for his allogenic liver donor transplant surgery. Treatment history. On March 2021, he was diagnosed to have supraventricular tachycardia and was managed with adenosine 6-mg IV fast push and was reverted back to sinus rhythm. At that time, BP was 200/110 mm of mercury, and lab investigation was suggestive of renal failure. He was started on antihypertensive and renal protective measures. Now he is on tab nifedipine 20 mg twice daily, tab carvedilol 6.25 mg twice daily, tab clonidine 100 microgram twice daily, and tab furosemide 40 mg twice daily. Along with thrice weekly hemodialysis, he is taking erythropoietin injection 4,000 units twice weekly. There is no history of blood transfusion. Past history. There was a history of pelvic abscess at 8 years of age, and open drainage was done under general anesthesia. And there is history of recurrent urinary tract infection in 2012-2016, which was treated with antibiotics. And herniorrhaphy was done in 2012 and 2016 under spinal anesthesia. There is no history of coronary artery disease, cerebrovascular accident, no bronchial asthma, thyroid dysfunction, or seizure disorder. There is no history of chronic intake of painkillers, no history of acute glomerular nephritis in childhood. Family history: father has hypertension, diagnosed at age of 35 years, and is on antihypertensive. There is no history of CKD in the family. Personal history: he's having normal sleep and appetite, not married. He is not habituated to alcohol or smoking. Fluid restriction is there to 800 ml per day. He's on mixed diet, which is a renal diet with salt and protein restriction. And there is salt is restricted to 4 gram per day and protein 50 gram per day. He undergoes maintenance hemodialysis through left radiocephalic fistula thrice weekly at a local hospital.
General examination. He is conscious, oriented to time, place, and person, thin built and moderately nourished, height of 158 centimeter with a weight of 53 kg, with a BMI of 21.2 kg per meter square. There is no pallor, icterus, cyanosis, club, generalized lymphadenopathy. Bilateral pedal edema is present. Vitals: pulse at 82 per minute, which is normal in rhythm, volume, character, no vessel wall thickening, no radioradial or radiofemoral delay. All peripheral pulses are palpable. JVP is not elevated, and blood pressure is around 148/86 millimeters mercury in sitting position on right upper limb. Temperature is normal. Systemic examination: AV fistula is present in the left arm, which is radiocephalic. Thrill is present. He has an IV access 20 gauge IV cannula in the right metacarpal. In the last 24 hours, his input was 795 ml with an output of 350 ml. Force was in situ. Last dialysis 24 hours ago, 2.5 liters removed, heparinized. And he has the pre-dialysis weight 55 kg with the post-dialysis weight 53.5 kg and a dry weight of 52.5 kg. Airway examination: airway is he has adequate mouth opening of 3-finger breath, Malampati grade 2, neck movements are adequate, temporomandibular joint movement is adequate, thyromental distance of more than 3-finger breath, and there's no loose teeth or dentures present. Coming to systemic examination: abdomen. On inspection, abdomen is slightly distended, umbilicus is in center, normal movement of abdomen with respiration, no visible pulsations, no visible gastric or intestinal peristalsis, and external genitalia is normal. Palpation: non-tender, no organomegaly. On percussion, there's no fluid thrill or shifting dullness, there's no organomegaly. And on auscultation, bubble sounds is normal, and there's no bruit or venous hump. Other systems: CVS on inspection precordium is normal, apex beat is not seen, and no other visible pulsations. On palpation, apex beat is felt at 5th intercostal space, half an inch medial to the mid-clavicular line, and there's no parasternal beep or thrills noted. On auscultation, S1, S2 heard, and there's no murmurs. Other systems: respiratory system, trachea is in mid position, and air entry is bilaterally equal in all areas, and there's no added sounds. Central nervous system, there's no neurological deficit. Summary: is a 32-year-old male, a known case of hypertension with history of hypertensive emergency, CKD stage 5, on twice weekly maintenance hemodialysis with left radiocephalic fistula with bilateral pedal edema, now electively planned for his allogenic living donor renal transplant surgery.
That was a good presentation, girls. Okay. Now, coming to the question, you said that your patient has got chronic kidney disease, stage 5. Well, could you define what is chronic kidney disease?
Chronic kidney disease is defined as glomerular filtration rate less than or equal to 60 ml per minute per 1.73 meter square for more than or equal to 3 months with or without kidney damage.
Okay. What are the various stages?
Stages, according to KDIG classification, stage 1 is GFR more than 90 ml per minute per 1.73 meter square. It is with kidney normally functioning. And stage 2 is 60 to 89 with mildly decreased stage, GFR of 30 to 59, moderate, and with GFR of 15 to 29, which is severe, and GFR less than 15, it is end-stage renal disease.
And most of the CKD is described in terms of the GFR, the amount of GFR that is present. Do you ever use serum creatinine as a marker for it, or a potassium hyperkalemia as a marker to describe CKD?
Usually we use glomerular filtration rate because serum creatinine, that is creatinine, is a byproduct of from skeletal muscle, that is creatine. So it can depend on the muscle mass of the patient. So we use GFR.
Yes.
And
yeah, there could be kidney damage. GFR has to be decreased to more than 50% before
50%
creatinine starts rising. That's one of the reasons. And also you must remember, how is GFR calculated?
It is calculated according to the Cockcroft-Gault formula, which is the creatinine clearance equal to 140 minus age into lean body weight by serum creatinine into 72 and into 0.85 if it is female.
That's right. And this is estimation of GFR by indirect method based on serum creatinine. It can be measured directly. How do you measure it? Any idea?
Direct can be measured by the inulin, with the help of inulin
clearance and creatinine clearance. All right. Okay. Is there any other classification of kidney disease that you know of?
Rifle criteria.
Right.
Is basically for acute kidney injury. Urine output and serum creatinine is used, and there are 5 parameters: risk, injury, failure, loss, and end stage.
Right, that's that. Okay, now that we've established what is CKD, what is the etiological factors of CKD? In your patient, what do you think is the likely cause?
In our patient, it is hypertensive, which is the cause for his CKD. But the most common cause for CKD in birth population is diabetes, which is followed by hypertension. And the other causes include chronic glomerular nephritis and tubular interstitial disease, and any obstructive causes and any vascular etiology like vasculitis or renal artery stenosis, and infections such as HIV could also be an etiology for CKD.
Any other congenital cause that can cause it?
Polycystic kidney disease, medullary cystic kidney disease, Alport syndrome.
You must remember that as well, because those patients present at a younger age. Joylyn, you want to take the next question?
Yes, ma'am. Girls, your patient presented with a plethora of cardiovascular symptoms, right? Accelerated hypertension, and he had arrhythmias, which was SVT, which was treated. So could you explain system-wise, beginning from cardiovascular system, what are all the presenting features or the...
Yes, ma'am. Coming to the cardiovascular system, the most common symptom you find is a systemic hypertension, which is due to the fluid overload, which is due to the rise in serum renin, and there is increased sodium and water retention, and there is an increase in cardiac output, and there can be an increase in systemic vascular resistance, and there is left ventricular hypertrophy, and thus there is increase in oxygen supply demand, and so electrolyte abnormalities can also cause various cardiac arrhythmias, and there is progressive atherosclerosis due to decreased lipoprotein lipase activities, and there is increase in the triglyceride levels, and there can also be an occurrence of silent MI, and in case of increased urea level, you can find a pericarditis, pericardial effusion, and other cardiomyopathies. Coming to respiratory system, they can have pulmonary edema, which is due to the fluid overload, and there can be pleural effusion, which occurs due to decrease in the on-court albumin levels, and there can be an exudation of the fluids, and they can also be susceptible for frequent respiratory tract infections.
Yes. They have reduced surfactant production and increased incidence of atelectasis, which is important to us as anesthesiologists. Okay. Then, Begum, could you tell about the central nervous system?
There will be mostly memory and sleep disturbances, uremic encephalopathy, high risk for seizures, peripheral neuropathy, autonomic neuropathy, and high risk for cerebrovascular accident if the patient is in erythropoietin injection, or in CKD itself is a high risk for coagulation.
And like Sir mentioned in the previous lecture about the dialysis dementia, that also you could include in the central nervous system, and disequilibrium syndrome, which happens. Yes, yes. Yeah. Then what about the hematological system?
Hematological, they are more prone for anemia, which is normocytic normochromic anemia, which is due to decreased production of erythropoietin and can be also due to the decreased lifespan of RBCs. And that is chronic bone marrow fibrosis, and can also be due to the dietary deficiency and also due to anemia of chronic disease. And there is qualitative defect of the platelets. So there will be an due to decreased aggregation and decreased adhesiveness of the platelets. There is decrease in production of 1 Willebrand factor and factor 8. So abnormal coagulation can be present. And
any idea how this is treated perioperatively? Are you aware of any medication for this? Factor 8, 1 Willebrand factor?
There's more present in injection
yes,
or
yes,
subcu.
yes. Very good.
Estrogen injection and
yes.
also can.
Yeah, good. Yeah. Then GI tract.
GI, there will be uremic symptoms. There also there will be gastritis, gastroparesis, and increased risk of GI bleeding, nausea and vomiting, and protein energy malnutrition is also there.
Yeah. Any other systems we missed out? Musculoskeletal and endocrine.
Electrolytes.
Yeah, electrolytes. Yeah.
There will be hyperkalemia. There can be hyponatremia, hypocalcemia, hyperphosphatemia, and because of that you have secondary hyperparathyroidism also, and there is hypermagnesemia. And there can also be metabolic acidosis.
Yeah. And the immune system?
No, mostly the patients will be immunologically compromised.
Yeah. They have both B and T cell dysfunction. Their cellular and humoral immunity is impaired, isn't it? Yeah. So if you have to summarize the entire...
mention here is if they have IgA mediated glomerular nephritis, they would be on immunosuppression as well. If that is the cause of CKD, they would be.
So the adaptation to CKD happens like in 3 stages. Like in the initial stages, you see problems with the creatinine and urea excretion, followed by when a certain percentage of nephrons get involved, then hyperkalemia sets in, and finally the sodium and water balance is lost when how the body adapts to kidney disease, isn't it? Ma'am, shall we proceed with the
I think we
treatment?
should go move on to the next. Now that we have a patient who's established with CKD, what are all the treatment options that's available to you?
There are renal protective measures in the initial stages we can follow. The patients can be by hypovolemia, can be hyper fluid overload can be treated with restrictive fluid, that is 1 liter per day, and protein restriction, salt restriction, and potassium restriction, potassium containing foods.
How does protein restriction help, and what has been the
protein catabolism can cause uremia and uremic symptoms and worsening of renal failure.
Right.
That can be prevented with protein restriction. Usually it is around 0.6, 0.7 grams per day, but these patients are high risk for protein energy malnutrition. It can increase up to 0.9 grams per day, per kg per day.
And what are the measures?
The measures, vitamin D and phosphate binder can be given, and tab acidose can be given, bicarbonate supplements can be given. Erythropoietin injection for treating anemia. As last start with maintenance hemodialysis, and for end-stage disease, transplantation.
Okay. Now that your patient was put on dialysis, what is dialysis and what are the types of dialysis? Because you need to know about what they exactly do.
So dialysis is diffusion of molecules across a semi-permeable membrane across against a concentration gradient. So the types of dialysis available are hemodialysis and peritoneal dialysis.
Right.
So
Okay. What
hemodialysis.
is, yeah, hemodialysis. Right. Go on.
So in hemodialysis, the blood is pumped through an extracorporeal system that incorporates a dialyzer. So in the dialyzer, the blood is separated from the dialysate solution by a semi-permeable membrane, and the solutes move across the membrane by obeying the fixed law of diffusion. So the dialysate solution is rich in bicarbonate, which diffuses from the dialysate solution into the blood, and the blood, which is rich in urea and potassium, diffuses into the dialysate. So so in order to maintain the concentration gradient, the blood and the dialysate moves in the countercurrent direction, and fluid has to be removed from the blood. The pressure has to be increased on the dialysate side so that fluid moves into the dialysate.
Right. Okay. And some patients do present to us with peritoneal dialysis or for insertion of CAPD catheter in these patients. Who are the patients who would be indicated for a peritoneal dialysis?
There is a failure of getting an AV fistula and children's.
Okay. An overt CCF patient, they will not tolerate hemodialysis. Okay, in those patients, you put them on hemodialysis. Any idea what SLED is? Where do they do it? Just
SLED is sustained low efficiency dialysis, which combines like both the filtration and dialysis, and it is cost effective when compared to an hemodialysis.
Okay. And, we've just come through the COVID pandemic, and we used a special hemofiltration for COVID patients. What did they use? Any idea? Know about it? There's a special hemofiltration which could bind to remove the cytokines, which would be combined with the hemodialysis. Just because we just come through it and some patients are put, I asked you this question. Okay, moving on. So your patient, what are the problems with dialysis? What questions should you ask the patient pertaining to dialysis? One is the patient's on dialysis, he's on maintenance hemodialysis. There are certain questions you should be asking your patient, which is important to us. What questions would you ask him?
Any allergies, high risk for allergies?
Yes, he's already on it.
Okay.
Any hypertension during?
How any hypotensive episode? Any hypotensive episodes in the previous dialysis sessions?
Right.
Any electrolyte imbalances? How much fluid is usually removed?
Right.
And whether it was heparinized or not?
And you did mention something about, I was getting to it. You did ask in your question, dry weight and how much fluid was removed. What is dry weight?
Dry weight is the weight of the patient after dialysis, in which the patient will be normotensive without the use of any antihypertensive, and there is no any features of fluid overload.
Right. Okay. Now that your patient is on dialysis and is waiting for a prospective donor, and he's also found to a donor. What about Joylin? You want to take it further from here?
Yes, ma'am. So now we will prepare your patient for the dialysis. We'll briefly discuss about timing, indications, contraindications of dialysis. Could you tell me when a patient is put on the transplant list, a CKD patient?
Usually, when the patient is reaching a CKD stage 4, it's an ideal time for the patient to be put on a transplant list. But due to non-availability of the ideal donor, they usually be put on a dialysis initially, and then when the donor is available, they usually get into a renal transplant.
Yeah, shortage of organs, basically. Yeah. So best is a preemptive transplant. Yeah. And it is the most cost-effective option. So who is your patient's donor?
Brother.
Brother. So could you tell me about the various donors you know of?
Living related donor. Living
Yeah.
related donor, living unrelated donor, and cadaveric donor.
Yeah.
The donors.
Any other donors?
Please.
We have a dead after, donors after a cardiac death and brain dead donors.
Kidney donation after circulatory death, DCDs.
Yeah.
Yeah, they don't meet the criteria for brain death, but yeah, they experience cardiac arrest after withdrawal from ventilatory support. So these people increase the number of organs which are available for donation. So what is the difference between the two? The graft function, any idea between the brain dead and the DCD donors?
DCD donors, their organ is taken after the circulatory arrest, so there is a deprivation of oxygenation to the tissues. So delayed graft functioning will be there. So we have to bypass after surgery with hemodialysis.
Yeah, but long-term graft function is almost the same.
Same.
How are the organs tested for compatibility? What are the various tests you know?
We do blood compatibility test. We look for the ABO compatibility, and there is tissue matching, where we look for the HLA antigen compatibility test. Ideally, at least six should be matched for an ideal donor, and then cross matching for the HLA antibodies, whether it is present or not.
Who is this cross match done on? Yeah, when is it done and who is it done?
It's done on the
donor blood and
the recipient blood. Cross matching is done.
It's cross matching is mostly done on the donor. Okay.
No. Okay.
Because donor serum has these antibodies which can trigger an acute rejection in the recipient, and it has to be done. Any idea when it has to be done? They keep repeatedly doing it till the time of the proposed transplant. Okay. Yeah. So that is one of the points you missed in history taking, about the sensitization history. If it's a female patient, always ask for pregnancy, and yours was a male patient, so history of past blood transfusions, because that, or any other organ transplant, because that sensitizes them to future cross-match related graft problems. Okay, so what are the indications? So we discussed indication, the absolute indication being
fluid overload
for transplant. Yeah.
There will be
irreversible, end stage renal disease with irreversible
and organ damage. Fluid overload unresponsive to diuretics, and electrolyte imbalances unresponsive to medical management, and if there is uremic encephalopathy, cardiomyopathy, pericarditis.
Are there any contraindications?
Contraindications.
There are absolute and relative contraindications. So absolute contraindications will be any presence of any malignancy and untreated infections, and severe any irreversible extrarenal diseases who are not psychiatrically sound, and any history of drug abuse. These are absolute contraindications. Relative contraindications.
Also, extensive vascular disease where surgically the anastomosis is not possible. Severe bilateral iliac or lower extremity vascular disease also falls under absolute contraindication. About the relative?
Relative, it would be any vesicle or ureterial abnormalities, and smoking. So relative contraindications.
Okay. Is presence of hepatitis B infection, hepatitis C infection contraindication?
No. In the donor, it is an absolute contraindication.
I think the hepatitis B patients are treated with interferons and lamivudine, and post-transplant they can't receive interferons, they can receive lamivudine. So on treatment they can. And hepatitis C virus infected patients can receive a kidney from a hepatitis C infected donor. It is not a contraindication. Yeah. And any other diseases like obesity, for example, preferably treated prior to transplant. Even severe coronary arterial disease, preferably to treat the primary disease, then go with the about the transplant.
Right. Okay. Now that you've established your patient is to undergo a transplant and you have a donor, what are the pre-op investigations that you would do in these patients?
We'll start with complete blood count, especially look for HB count, whether there is anemia or not. platelet count.
There will be
Usually
anemia with CKD. So
yes, we have to optimize before surgery.
what
Typically,
is an optimization level that you take these days?
ideally 11 to 12 milligram per deciliter.
Would you want it more?
No, ma'am.
Why?
It increases the risk of thrombosis. So
Sorry?
increases the risk of thrombosis. So
One
I
is that.
ideally
Yes.
maintain
Second,
that.
what is the other reason? Viscosity goes up. So perfusion may come down theoretically. That's the reason why you say not beyond 11 or 12. Okay. Okay. Other investigations.
If the patient is diabetic, we'll look for the blood sugar
Tell
count.
me about complete blood count, you said. What
Okay,
about the
complete
total count? Don't you want to
total
rule out any ongoing
Infection.
infection in your patient?
Yes, the total count will check to rule out infection. Platelet count, usually it will be normal, but there will be qualitative platelet dysfunction only. And we'll go with serum electrolytes, potassium, sodium, magnesium, calcium, and phosphate. Then a renal function test, serum urea, serum creatinine, blood urea nitrogen, and urine routine. Then
Yeah, right. You'll order all these. You remember you spoke about all the pathophysiology on the various systems. So you need to make sure all those systems are functioning well, or at least optimized as good as it can be. There could be hyperkalemia. If there is hyperkalemia, you've got to treat hyperkalemia. And I'm sure you know the treatment of hyperkalemia. We'll not dwell on it because of constraint of time, but for the other students, you might be asked about hyperkalemia treatment, which you should be knowing. Okay, what are the other investigations?
You look for the coagulation test, PTNR, APTT. APTT can be prolonged due to use of the heparin during dialysis. And then you look for screening for other infections like HPV, HCV, HIV, screening tests is done. And then you go for blood grouping and cross-matching.
Okay.
Be done. And you take an ECG to look for any changes which can be due to the pathological serious manifestations like left ventricular hypertrophy or any other arrhythmias, and electrolyte abnormalities can be looked for. The features of electrolyte abnormalities can be seen in ECGs, and the chest X-ray to look for any fluid overload or pleural effusions, and any other to rule out any other respiratory tract infections.
Okay.
And you take echo to look for the
When
base.
do you want the echo done?
Ma'am?
When do you want the echo done? See, your patient has been waiting for it, he's been prepared for it. Echo was done 3 months earlier. Do you want to repeat it or no?
yes,
Yes, ma'am.
repeat.
Why is that?
Because we know the fluid overload can happen anytime between those periods.
That
So
apart?
Electrolyte.
That apart?
and to look for any pericarditis or pericardial
You must
effusion.
remember, yes, pericardial fluid could be there. In addition, you must remember that these patients are high risk for a coronary artery disease.
Artery disease.
Reason being, they'll have accelerated atherosclerosis. And they will have an LVH as well, which could be there, cardiomyopathy, which could be there, which is all a consequence of your CKD. And you should, another thing that you ought to remember in these patients is that this hypertension could be the cause of CKD. It could also be a consequence of your CKD. Right. Okay. Now that you have ordered all your pre-op investigations and you're satisfied that is okay, you can take him up. What is a pre-op instruction or advice that you give to the patient? What all do you do?
We'll tell the patient to follow the renal diet and to follow the maintenance hemodialysis correctly, and have to take dialysis prior to surgery.
When?
And
Exactly when? Day prior. Okay. Is posted
24
tomorrow. 1 minute. Is posted
Okay.
tomorrow at 9 o'clock. So can he undergo dialysis today evening at 6 o'clock?
Yes, ma'am. Yes, ma'am.
Yes. Yes.
6 hours, actually 6 hours gap is okay.
Okay, but ideally,
12 hours.
24 hours.
since it's an
24.
elective procedure,
24 hours prior to surgery is
24
ideal.
hours prior. Okay. Why do you say 24 hours prior?
So that whatever the electrolyte imbalances can be corrected during that time.
Yeah,
And
electrolyte imbalance and also the
heparin can be metabolized during that.
6 hours for heparin, electrolyte imbalances, whatever fluid shifts that has occurred takes about 24 hours. Okay, then what other instructions would you give it?
If the patient is hypertensive, since our patient is hypertensive, we have to tell the patient to continue the antihypertensive except ACE inhibitors and ARBs.
Yeah,
And if the,
but your patient was not on ACE or ARB. Now, what is the relevance of ACE or ARB with these patients?
there will be hypertension, refractory hypertension, which we could manage with vasopressors at the time of induction or
intraoperatively, mostly because they'll have refractory hypertension, and hypertension is not good for your organ perfusion. Okay. Then what else?
Then strict GRPS control, blood sugar control should be there. We'll check your previous day blood sugars, and we'll control the with insulin bolus or injection, and have to repeat the values day of surgery also. We'll ask them to arrange liquid blood and blood products, which is lipo-reduced and irradiated blood. Counsel the patient about the surgery and surgical procedures. Then we'll go with pre-medication. We'll give pre-medication.
Pre-medication, yes. Okay, what pre-medication would you order?
We'll give one proton pump inhibitor like pantoprazole on the day before, on the night before and coming morning of the surgery. Metoclopramide is usually can be given, but it's usually avoided because 20% of its excretion is dependent upon the renal and can be prolonged duration of action. And we usually avoid sedatives, and usually immunosuppressants are started 2 to 3 days prior to the transplant. So those immunosuppressants should be continued on the day of surgery.
Yeah, we'll talk about immunosuppression later because there are some which we give intraoperatively also. Okay. Then what else? Okay, you've prepared your patient. He comes into the theater. So how do you prepare your theater, and what monitors, what is your technique first of all? You've got to explain to the patient that you're going to use this technique. What is your preferred technique?
General anesthesia with abdominal block.
Okay. Why? Okay. Why general anesthesia? Why not epidural?
Because general anesthesia will have a better hemodynamic stability, and if it is a long surgery, it will be better if we choose a general anesthesia. And
duration of the surgery has no bearing on your choice.
Okay.
Okay. But the reason that you don't want to give, or at least I would not want to give also, is different.
Okay. Epidural anesthesia will be having a profound hypotension, which will affect graft functioning. So we have to avoid that. Risk of spinal hematoma will be there.
Yeah, there could be, patient could have uremic coagulopathy. That's one of the reasons why you don't want to give epidural. And if it is, anyway, you've decided your mode of anesthesia is going to be general anesthesia, pain as such, you have other modalities to control post-operative pain. So epidural, and sometimes, the patient can go in for delayed graft function, in which case you might have to dialyze the patient, so putting an epidural may not be ideal. Okay. And Joylyn, you want to take it further from here?
Yes, ma'am. Okay, can you hear me now? I lost you all for a while.
Sorry. Okay.
You can hear me, right?
Yes, sir. Yeah, I can hear you.
Yeah. So
we finished up till now induction technique. Now they have to.
Okay. The pre-medication bit, did we finish?
Yes, ma'am.
Okay. So can you explain the surgical procedure for a renal transplant?
Surgical, it is an open surgery. So where the incision is from the symphysis to 2 to 3 centimeter supromedial to the anterior superior iliac spine. The incision is known as the Gibson's incision. And once the muscle layers are retracted, external iliac vein and external iliac artery is exposed. And once the donor available, the donor's renal vein is anastomosed end to side to the external iliac vein, and donor's artery, it is anastomosed end to side with the external iliac artery in the recipient. The ureter is anastomosed to the urinary bladder. And once the transplanted kidney surgery is confirmed and the color is confirmed, the kidney is planted in the extraperitoneal iliac fossa, and it is the muscle layers are sutured afterwards.
Yeah. What about the ischemic times? Could you shed some light on the warm and the cold ischemic
There is
times?
warm ischemia time and cold ischemia time. Warm ischemia time starts from the clamping of renal arteries in the donor till it reaches the eyes, and cold ischemia time starts from the till from it reaches the eyes to re-anastomosis in the recipient.
What are the ideal times?
Warm ischemia time should be restricted with 3 to 5 minutes, and cold ischemia time in case of a living donor should be restricted to 30 to 45 minutes. And if it's a cadaveric donor, up to 24 to 48 hours, it can be stored in the ice.
Yeah. So along with induction, there is some and the antibiotics. There is something else we have to give in transplant patients. Some other induction happens of the immunosuppressants. Yeah.
We give IV methylpred 10 mg per kg 30 minutes prior to the reperfusion, and mannitol and IV furosemide 40 to 80 mg is also given to promote the diuresis and the graft functioning 30 minutes prior to reperfusion.
You didn't understand the question. She said, Dr. Joylin asked about some other induction apart from induction of anesthesia. Immunosuppression.
So induction phase and maintenance phase of immunosuppressants.
Yeah, go on.
We usually give immunosuppressants to prevent the graft failure or rejection. So there are two phases, inductive phase and maintenance phase. Inductive starts before renal transplant, 3 days ideally, and it will continue up to 3 weeks post-transplant, and maintenance phase after that. Inductive phase, we give steroids, a calcineurin inhibitor, and an antimetabolite. And we also give ATG infusion day before surgery. And after surgery, for 1 week, if the patient is less immunosuppressive, we can avoid steroids and continue other drugs, calcineurin inhibitor like tacrolimus or cyclosporin, and antimetabolite like mycophenolate mofetil and azathioprine. And steroids usually methylprednisolone.
Okay. And, any immunosuppressant agents that we give it on table, anesthetist administer?
Methylprednisolone.
Methylprednisolone is one. Any other thing?
Antibiotic?
No, I'm not talking about antibiotic. Interleukin-2 antagonist, Vasileximab. Yeah, we do give that on table. We also sometimes in some centers, we give Vasileximab at times, but in some centers they give anti-thymocyte globulin.
We give anti-thymocyte globulin day before surgery as infusion.
Yeah, day before, and also sometimes they do give it on table as well. And any idea what you need to monitor or what you need to be aware of when you're giving this?
They're more prone for hemodynamic instabilities, like hypertension will be there during
hypertension, bronchospasm, tachycardia can occur.
Allergic reactions.
Yeah, allergic. It is a possibility. It's a reaction that they have for this. So what precaution do we have to take? This is for the benefit of the students as well, that you need to know this. We are giving another immunosuppressant. Administer methylprednisolone before giving your antithyroid. ATG. Okay. Right. Okay. Right. What you said your mode of technique is general anesthesia. So what induction agents would you use in these patients?
Actually, I will give,
you would do a pre-oxygenation, yes?
Pre-oxygenate the patient. I will give anxiolytic, preferably midazolam, 2 mg. Then we'll give short-acting opioid, fentanyl, 2 microgram per kg IV. Then we'll give propofol as induction agent, which is
how much of propofol?
Incremental dose.
In titrated doses till the verbal response is lost.
Okay.
You have to reduce the dose of propofol?
Ideally, no, ma'am. But if to maintain the hemodynamic parameters, we give a titrated doses till the verbal response is lost.
Okay.
Cardiovascular suppression is exaggerated, but at the same time, the circulation is hyperdynamic. So to reach the hypnotic levels, both get negated, isn't it? If you have to attenuate the laryngoscopy response, since your patient is hypertensive, what can you do?
Can give lignocaine 1 mg per kg at the time IV at the time of injection, induction.
Yes. Any other drug?
Then
No.
Any beta blockers you know of?
Esmolol can be given.
Esmolol can be. But there is a small risk of hypotension also if you attenuate the response too much.
Yeah. And whenever you're administering all the drugs, what should you remember about the alteration in pharmacokinetics in these patients? Sir spoke about it, but I thought just to reiterate, you've got to remember.
Renal excretion.
Yeah, one is clearance of the drug, active metabolite, which could be cleared by the renal excretion. Then
there is increased volume of distribution.
Correct.
And there's hypoalbuminuria. So there is increased availability of free blood.
You've got to remember and judiciously balance and your drugs that you're going to be giving. Right. Okay. Induction is with propofol. Is thiopentone a contraindication?
We have to decrease the dose because it is protein bound. So it will have a prolonged duration of action.
What about etomidate? Cardiostable? Why aren't you?
Can be given, ma'am. Can be given
or not?
Can be given.
But what is the problem? We are not using it. Adrenal suppression.
Okay.
That is the reason. Cortical suppression. Okay, that's one of the reasons why they say theoretically some authors do not advise you to give etomidate. However, propofol can be used. Okay. Then, what is your relaxant to aid your intubation?
Okay.
Sorry?
I was asking them about ketamine.
Okay, ketamine. Sorry, I didn't get that.
We avoid ketamine because it causes a transient hypertension.
Yeah.
So we avoid ketamine in CKD patients.
So the pharmacokinetics is preferable, right, of ketamines, but still we don't use it because of the unwanted hypertensive response. Yeah. So ma'am was asking about the neuromuscular blockers. Could you tell about the use of scoline and preferred NDMR?
We'll go with a rapid sequence induction. We'll preferably give scoline if the potassium is less than 5 milliequivalents per liter, and we'll give 1 mg per kg scoline and you the patient. For maintenance, we'll prefer cisatracurium.
For some reason, if you can't use scoline,
we can give cisatracurium at the time of injection.
You can give cisatracurium in the dose of
0.15 mg per kg.
3 times ED95. You remember that 3 or 4 times higher dose. Theoretically, yes, rocuronium, some do say, but 20% is excreted in the kidney, so no. Okay.
But now that we have availability of Sugammadex, can you use it in chronic renal failure?
Better to avoid.
Better
It's
to
better if we avoid.
Yeah, I think it is not recommended for people with creatinine clearance less than 30. So we can't use it on for patients on renal replacement therapy.
We're talking about sugammadex. Okay. Right. Okay. Next. Right. How do you maintain these patients?
Volatile agents. Yeah.
Volatile agents.
Isoflurane is preferred over sevoflurane.
Sevoflurane, yes, no.
Can be given, ma'am, but it has the formation of compound A with the soda lime, so which is nephrotoxic. So we tend to avoid sevoflurane and iso.
Okay. And what is the recommendation about using sevoflurane? Any idea?
Can be
Flow rates. I think ma'am is asking the flow rates.
flow rate.
Yeah.
At low flow, it can be given, ma'am.
No, you should not be giving it with very low flows.
Yes,
Because with very low flows, this compound A formation
Formation
more
is high.
pronounced, isn't it? More chances of it. So you don't go on very low flows if you're using Sevo. Provided you're using above 1 liter, then you can do it.
For a
Alright?
1 hour case, I think it's around 1 liter, and more than an hour, 2 liter flow is recommended.
Okay. Right. All right. Okay. What about your relaxant done and your other maintenance drug, pain, fentanyl, you said?
Opioids, ma'am.
Opioids.
We usually give fentanyl for in CKD patients. Avoid morphine and pethidine. Morphine metabolites are excreted in kidney, and there is increased respiratory depression post-op, so there will be delay in extubation and all. And for and we'll maintain with cytokines as relaxant, intermittent boluses.
Okay, we got it.
We'll
Sorry, I lost you. I can't hear you.
No,
I can't hear you. I said.
We didn't hear, I didn't hear what you said.
actually,
Prefer fentanyl, avoid pethidine and morphine.
morphine.
Okay.
What
And
about
now, you've started. What are your goals for anesthesia? We should have actually discussed this at first, but it doesn't matter.
Actually, there will be normocapnia, normoxina, with avoiding acidosis, and maintain a proper depth of anesthesia with inhalation agents and muscle relaxant. And IV fluid should be maintained. Before anastomosis, the CVP should maintain between 9 and 10. And after anastomosis, increment to 10 to 12 centimeter of water.
Is that what it is said? Okay. What about your math?
It should be maintained.
Math in arterial pressures?
Than 90 millimeters. It should be more than 90 millimeter of mercury because the transplanted kidney is denervated, so there won't be any auto regulation of blood circulation in the kidney. So there is a high chance for rejection if you reduce the MAP. And adequate dialysis should be maintained. Can give mannitol and Lasix before anastomosis.
Okay. And what monitors would you be using?
We can use an invasive blood monitoring, and
is that mandatory?
Not ideally mandatory, but it would be better for us to have a hemodynamic control if there is an invasive BP monitoring. And
monitoring.
CBP?
CBP to be central venous to be monitored for adequate fluid management.
Okay. Your voice is breaking a little. Do you feel so, Joylyn?
Yeah, ma'am. Yeah. Slight.
Your voice is breaking a little.
Now I can't hear them. I think we've lost them.
We've lost them, yes.
Yeah, they're back.
Hello, ma'am.
They're back.
Hello.
Yeah. Go on. Go on.
So we'll keep invasive monitors like arterial blood pressure and CVP for better fluid control and for blood gas analysis and all.
And temperature?
Temperature monitoring should be strictly followed.
Why is that important?
If in case of hypothermia, there will be an exaggerated platelet dysfunction can be there, and there can be decreased metabolism of the anesthetic drugs we give. So there will be prolonged
Vasoconstriction.
and vasoconstrictions.
Then, what about neuromuscular monitoring? If you have it, do you want to use it?
If it is available, we can use it. It will be helpful for us to
Titrate your
time our
dose.
dose.
Okay. Right. So far, we've spoken about what kind of fluid would you be using intraoperatively?
We'll give ID. If the potassium is less than 5, we can use balanced salt solution like Ringer lactate. If the potassium is high, we'll use half NS plus bicarb. Ideally, normal saline is avoided because of hyperchloremia and hypochloremic acidosis and thus renal failure.
So what kind of normal saline can you use? What is it recommended?
Half normal saline with an addition of bicarbonate to make it isoosmolar.
Yeah, it is recommended that you can use it. It's not that you completely avoid it. You don't want to over transfuse with normal saline. So, right. And okay, once the anastomosis, you were talking about the surgery, once the anastomosis is done, and whatever you need to take care during reperfusion that occurs, or what are the problems that can occur once the anastomosis is released?
Once they release the clamp, there can be an hypotension due to the free radical disease and the vasodilation of the lower extremity. So there can be a BP fall. So we should avoid the BP fall with adequately filling the patient with IV fluids and maintaining the CP. And should take care because there was a brief period of anaerobic metabolism in the tissues in the lower limbs. So there can be increase in the lactate levels and worsening the metabolic acidosis. So that should be corrected accordingly to the blood gas analysis.
And this acidosis and metabolites coming in can also cause arrhythmias.
Arrhythmias.
Okay. You need to be vigilant of these things when they've released the clamp, you know. Right. Joylene, you want to take it further?
Yeah. Can you use any adjuvants to improve the graft function?
Adjuvants to improve the graft function. We give drugs to promote the diuresis, ma'am, which that improves the graft function. Like mannitol, 20% we give like 100 ml, and IV furosemide at 40 to 80 mg IV can be given.
What dose of mannitol is recommended?
It's actually 0.5 grams per kg.
Yes. Causes osmotic diuresis, free radical scavenging, and also some amount of renal arterial dilatation.
Okay.
What happens to the reversal agents in chronic kidney disease now that we've reached anastomosis and they are closing? You have done a ABG and everything is looking all right, and you want to reverse and extubate your patient. What happens to the reversal agents in CKD?
Actually, there is the prolonged duration of the neostigmine and pyridostigmine action is prolonged in CKD patients. Since now we have transplant is done and the kidney is now functioning well, so we can.
Kidney apparently has the ability to clear the neuromuscular blockers as a new kidney. And like you said, the clearance is dependent on renal excretion, 50% for neostigmine. Yeah. So how do you go about reversal and extubating the patient, and what is your plan for post-operative pain management?
We'll give the normal dose reversal and extubate the patient. We'll avoid any stress response during extubation. There will be enough gap between the muscle relaxant, and the patient should be fully awake and responding to the commands. A post-operative pain relief, mostly opioid infusion can be given, usually fentanyl infusion, and paracetamol is given. We strictly avoid NSAIDs, and we can go with a block, abdominal plain blocks like transverse abdominis plain block or erectus spinae block.
Any particular attention you have to pay in CKD patients when you use local anesthetics?
Can be given, ma'am, but dose can be reduced.
The minimal dose required should be used because they're very sensitive to it. And you have to bear in mind they have neuropathy because of uremia. They are more prone to seizures, platelet dysfunctions, and residual heparin action. All that you have to keep in mind when you are using the local anesthetics in them.
And a word about fluid management post-operatively. How much of fluids would you be giving?
100 ml per 100
ml. Is that what is recommended? Because obviously, you know, almost about 70% of live donors and about 50% of 90% of the live donors and 50% of the cadaveric donors will start diuresing on table. So your urine out, your fluid management once the patient start diuresing should be the previous hour's urine output plus 100 ml.
Okay.
100 ml is your maintenance. You need to replace what fluid is coming out. So post-operatively, there are three things that you monitor. One is the urine output. You'll also do an RFT repeat, and you'll keep an account of the lights that's coming down. You don't want any. You must remember that the kidneys are stored in the preservative fluid. We did not talk about the fluids used for preservation of the kidney. So what are the fluids that's used for preservation of the kidney?
You have University of Wisconsin fluid and custodial HTK fluid, which are used now.
Right. Okay.
Whose
Which one would you
composition?
prefer?
Custodial HTK is preferred.
Why?
Because its composition is similar to the ECF, and it has an osmolarity around 300 to 310 milliosmoles per liter.
Right. Okay.
Not extracellular, intracellular. High potassium.
Okay. So those things that you need to monitor. What complications can you expect on table or immediate post-operative period in these patients?
There will be hyperacute rejection of the graft. So
right.
Because of the preformed antibodies in the recipient can be due to transfusion or any other sensitization before.
Okay. What other problem can occur?
There will be decreased urine output, increased potassium, and other bleeding will be there. Urinoma will be there because of urine leak.
And sometimes what happens is that you could have vascular issues also. Thrombus in the renal artery or the renal vein, which could be a cause. So in which case they'll have to reopen, take out thrombus that's there. You know, they do come in for reopening after about 3 or 4 hours. And sometimes it could be just delayed graft functioning. So in which case you might have to dialyze the patient. And we spoke about everything about except care of the AV fistula on table, which is very, very pertinent. One. Second, you do not put a line in the same arm as the AV fistula that's there. No blood BP cuff to be put in that arm. And ideally, you should pad it a little and take care that it is functional. Because sometimes they may need it post-operatively for dialysis. Right? Any other thing, Joylyn? Anything else?
Just can you briefly tell about your concerns for patients post-transplant when they come for any other incidental surgeries?
Post-transplant patients are usually on a long-term immunosuppressants. So we should initially assess the functioning of the graft, how the graft is functioning now. So we take a serum creatinine, or we can radiological investigations can be done. And then we had to rule out any, since they are on a long-term immunosuppressants, you have to rule out any potential infections they have, which can be masked. So we look for any history of fever or blood counts like leukocytosis can be seen. And you have to see whether there is any side effects of a long-term immunosuppressants. So which could be an onset hypertension, lymphoproliferative disorders, or any glucose intolerance can be done due to prolonged steroid use. Adrenocortical insufficiency can happen because of long-term steroid use.
Yes.
And
they might not respond to infection with leukocytosis because of the immunosuppression. They are usually cytopenic. So we have to be very careful when we induce patients, take all precautions so that we don't become a source to give them any infection. Otherwise, your plan of anesthesia doesn't necessarily change.
similar to a normal CKD patients.
Procedure the patient comes for.
Similar to a normal patient, because his kidney is already functioning with, say, maybe kind of immunocompromised patient that you would take care of. Strict asepsis to be followed. They're more prone for infection, IV lines, and gloved up, all those other things. And technique of anesthesia is not going to change. Whatever is suitable for the surgery, you can use.
Yes.
Okay. And there's the benefit of the students who are listening. We did not discuss anything about the donor nephrectomy. Donor nephrectomy is essentially like the other nephrectomy, with the difference of being that you will adequately hydrate the donor, one. And second, it could be done laparoscopically or open method. If it is an open method, you would put in an epidural catheter for post-op analgesia, and then general anesthesia is your technique of choice. And prior to clamping, about half an hour prior or 1 hour prior to clamping, you would be giving mannitol for diuresing, and you will give enough fluid to maintain a urine output in excess of 1 ml per kg. Normally, we would be satisfied with 0.5 ml. And in this, we monitor this. And the word about cadaveric donor, we follow a rule of 100 there in those patients. That is, we have a systolic pressure maintaining above 100. You know that, girls? Can you talk about it if you know?
Systolic BP more than 100 millimeters of mercury, hemoglobin more than 100 gram per deciliter, and CVP more than.
CVP, we don't put it in the donor, no? What other under?
Saturation.
PaO2.
PaO2.
Oxygen level to 100. And now they've added another 100 of having normoglycemia. So 100 milligrams per deciliter of glucose as well. So that's another entirely different topic on its own. And I think, Joylin, we've managed to cover. There's so much more to discuss. And I think because of time constraint, we just stuck to what was the topic. And with this, I think we should be finishing. And I must appreciate both Dr. Begum and Dr. Varshini. You all did a good job. Thank you very much. And Joylin, it was a pleasure co-moderating this session with you.
Same here, ma'am. Thank you so much.
And forward to you.
Very well done, girls.
Yeah.
Thank you.
Dr. Sripada and
thank you, madam. Thank you, Geeta, madam. Thank you, Joylin. Thank you, Ashwini and Dr. Begum.
And
Very much for excellent discussion.
Thank you, sir.
Thank you, sir.
we will now. Is there any questions? I would like to know if there are any questions, please put them in the chat box. I don't find any questions in the chat box. Thank you, Dr. Geeta, and thank you, Dr. Joylin, and Varshini and Begum for an excellent presentation. You make your teachers proud. I should pass on this message to Amrita madam. I'm sorry, Lakshmi madam. Okay. I'll
Thank
pass
you.
on the message. Thank you.
Thank you so much.
Thank you, girls.
You had two pleasant teachers to ask you questions. I think it was really good, smooth.
Yes, thank you, ma'am.
Welcome.
We are
And
happy to have Dr. Ramachandra, Dr. Vijayanand, Dr. Hemlata, Dr.
Dr. Alex Philip, you
Alex
have
Philip,
to add in.
and so many of my friends are there.
Thank you, Sripad. It was a very, very nice discussion, and the postgraduates are very, very good. As Sumalata was telling, thanks to Dr. Lakshmi, the great teacher of Amrita.
Thank you.
Yes.
Thank you. Excellent, excellent. We are doing a great program with Nitte, with a great platform. We really go ahead. A long way to go.
Thank you.
Congratulations.
Thank you.
Namaskar, sir.
Namaste, sir. Agidira.
Ram, sir.
Yes, sir. Thank you so much for joining.
Yes, sir.
I also see Dr. Krishnaya Shetty joining in.
He was the one who was talking to you just now.
Right. So if there are no questions, I think we'll move on, Dr. Suma.
Yeah. Since we're not getting any questions, and I think they're very exploratively handled this case, we will now move on to the equipment of the month, Endotracheal Tube by Dr. Ravi, who's a professor from Sri Devaraja's Medical College, Kolar. Over to you, Dr. Ravi.
Good evening to all. So at the outset, I would like to thank, am I audible?
Yes, sir,
Yes.
you are. Please share the screen.
Yeah, I'll do that. Dr. Sripad and team, thank you for displaying the screen. I'm seeing a lot of my seniors and friends across. Okay.
Welcome, Ravi.
Yeah. So, can I go ahead?
Yeah.
It's visible? Screen is visible.
You're
Yes, sir.
visible and we can
Visible
hear
and
you.
audible, yeah.
Sure, thank you.
And please go on full screen, sir.
Yeah. Sure. Play. Okay. Is it full screen now? Is it full screen now?
Yes, yes, Ravi. Please go on.
Yeah, sure. So the topic given for me was endotracheal tubes. I would like to acknowledge my resident, Dr. Shravanti, for helping me with the slides. So this is my team at SDMC Kolar. So I'll be talking briefly on history, the general principles of the endotracheal tube, basic design and the parts, the special tubes, size selection, and a little bit of sterilization. So just a brief history. It's quite interesting also. The first tracheal tubes were developed for the resuscitation of drowning victims. 1 second. Minimize. 1 second. Minimize. Okay. Go back to play. Okay, fine. Sorry for the interruption. The first use of elective oral intubation for anesthetic was undertaken by the Scottish surgeon William Massivon. And in 1888, O'Dwyer designed the rigid tube with a conical tip that occluded the larynx. And most distinguished innovator in the tracheal intubation was Sir Ivan McGill. He developed a wide bore tube that would resist kinking, but also be comfortable to the contours of the upper airway. So in 1926, Arthur Goodell began a series of experiments that led to the introduction of the cuff tube. And he fashioned the cuffs from the rubber of dental dams, condoms, and surgical gloves that were glued out into the outer wall of the tubes. So also he was famous for the dunk dog experiments. If you go to the Wikipedia, it shows, along with Ralph Waters, he has done an experiment. The picture it is showing there. So he has used a cuff tube, and to make sure there is no leak, the dog was immersed in a water tanker and continuous ventilation was done. Okay. The endotracheal tube is a device that is inserted through the larynx into the trachea to convey gases and vapors to and from the lungs. So the general principles, we talk about the resistance and work of breathing. The tracheal tube places a mechanical burden on the spontaneous breathing patients. The factors that determine these things are internal diameter, the length, and the circumference. One second. Yeah. So tube with a thick wall decreases the internal diameter and thereby increases the resistance, and vice versa. Decreasing the length of the tube also decreases the resistance. Any abrupt change in diameter and direction also increases the resistance, as is seen in your north and south pole tubes.
Sorry, sir, to interrupt.
Yeah, sure.
Asking all delegates to keep their keep them mute because it's disturbing the presentation. Sorry, Dr. Ravi.
That's okay. Can I continue?
Yes, please, sir. Continue, please.
So the configuration, there's the abrupt change in diameter and direction increases the resistance, and curve connect less resistance than the rigid angle ones. There will be increased resistance because of the turbulent flow of the gases. So coming to dead space, the volume of the tube and the connector is usually less than that of the natural passage. So dead space normally is reduced by the intubation. In pediatric patients, long tubes and connectors may increase the dead space considerably. So we can cut the tube after the angle of the mouth if it is very long. The tube material ideally should be low cost, inert, and lack of tissue toxicity. So smooth, non-wettable outer surface to avoid damage to the mucosa and the inner surface to prevent building of tissue. It should be non-inflammable, transparent, and easily sterilized, and sufficient body to maintain its shape during the insertion and to prevent occlusion by torsion, kinking or compression by the cuff or external pressure. Sufficient strength should be there to allow for a thin wall construction, and thermoplasticity to confirm the anatomical passage and to be self-centering within the trachea, and also to be non-reactive with the lubricants or agents, anesthetic agents, and latex-free. So most of the colleagues and seniors there may remember we were using these red rubber tubes. So pros can be it is easily cleaned, sterilized, and multiple times it can be used. The cons are non-transparent, they harden by time and become sticky with age, poor resistance for kinking, and latex allergy is one more thing. So PVC's pros are inexpensive, compatible with tissues, and less likely to kink. So if you take a classical endotracheal tube with a PVC, just you can see the parts. So it starts with a connector at the proximal end. That's a 50 millimeter standard thing, along with the markings and the radiopaque line to see in the X-rays. And there is a pilot balloon and a pilot valve where it is a one-way valve to inflate air or deflate the cuff. And there's a Murphy's eye for the right upper lobe. And there is a bevel. So initially, we could see in the red rubber tubes, the bevel for the nasal and the oral tubes would be different. But as a PVC tube, it is the same. And the cuff is a high volume, low pressure cuff. So coming to the cuff systems, it provides a seal between the tube and tracheal tube to prevent the passage of pharyngeal contents into trachea, and whenever we are sharing the same airway, like in a DL scopy or any tonsil, etc. and also ensures no gas leaks past the cuff. And the cuff also serves to center the tube in the trachea when inflated. So what we are using, there's a PVC tubes with a low volume, high pressure, there's a red rubber tube. So there's a small diameter at rest and low residual volume. Advantages are, they are reused, less expensive, often better protection against the aspiration, and better visibility during intubation with low pressure cuffs. Also low incidence of sore throat. Disadvantages, most serious risk associated with these cuffs is ischemic damage to trachea following prolonged use. So high volume, low pressure cuffs, that are the things we are using now. Has a high residual volume, large diameter and thin competent wall. Advantage, it is relatively easy to pass devices such as the esophageal cystoscope, temperature probes, nasogastric tubes around the low pressure cuffs. Disadvantages are, tubes are more difficult to insert, obscure the view of the tube tip and the larynx. The cuff is more friable and thus most likely to be torn during intubation. These things we observe whenever we are doing unprepared nasal intubation. The use of nitrous oxide, like the resting intercuff pressure and the volume of the cuff inflated with air rise during nitrous oxide anesthesia, which results in ischemia of the tracheal mucosa, compression of the tube, and increase in the volume may also lead to cuff herniation. So nitrous oxide, if you are using cuff pressure monitoring, can be mandated in the long-standing surgeries. So some of the special tubes which are not using now, this is one of the Coles tube with the tip which will be having a lower diameter. So it's uncuffed tube and patient end is smaller, diameter is lesser than the shaft. The size according to the internal diameter of the tracheal portion ranges from 2 to 5 millimeters. Recommended for neonatal resuscitation, but not for long-term intubation. Disadvantage, cannot be used nasally. So some of the free-form tubes everybody is using, also called as ring Adair and Elvin. The south and north-facing tubes, most of the facial-maxillary surgeries and cleft lip, palate, tonsils, these things are used. So it's a free form to facilitate the head and neck surgeries, available in cuffed, uncuffed, nasal, and oral version. There's free form bend in the tube that may be temporarily straightened during insertion. Each tube has a rectangular mark at the center of the bend. Distance from this mark to the distal tip is printed on each tube. When this mark is at the nares of the teeth, the tube will be satisfactorily positioned in the trachea if it is appropriately sized tube. Advantage is easy to secure and reduce the risk of unintended extubation. Breathing system remains away from the surgical field, and long length may make them useful for insertion through a supraglottic airway device also. Nasal tube can be used for oral intubation for surgeries in the prone position. Disadvantage, suction is difficult because the preformed angle offers more resistance than the conventional tubes. Designed to fit the average patient, so a tube may be either too long or too short for a given patient. So some of the spirally embedded tubes or reinforced tubes or armored tubes. These tubes have a metal or a nylon spiral woven in reinforced wire covered both internally and externally by the rubber or silicone. Spiral may not extend into the distal and proximal end. Stellate may needed for oral intubation. These tubes are especially used in situations where the tube is likely to be bent or compressed, as in head and neck surgeries or prone position, spine surgeries. The only thing is, whenever we remove the connector and if it's deformed, this wire can be dislodged also. Primary advantage is resistant to kinking and compression. Portion of the tube outside the patient can easily be angled away from the surgical field without kinking. Disadvantages are tube may rotate on the stellate during intubation, and insertion to nose and intubating LMA is difficult. Elastic recoil force may increase tendency to unintended extubation. There's one more tube, the laryngeal tube, designed for insertion into tracheostomy site. Tube is freeformed in a J-shaped configuration at the patient end, allows the part of the tube external to the patient to be directed away from the surgical field. The tip may be short or without a bevel to avoid inadvertent advancement into the bronchus. Disadvantage being the soft cuff and the short distance between the cuff and the distal tube of the tube may cause the bevel to abut the tracheal wall. So double lumen tube, motive for lung surgeries. So this has two lumens, and history says white and Carlens with the Carlens hook and those things. So Robert Shaw is most commonly used. So the blue is usually a tracheal cuff, and the white will be, the white is tracheal cuff, blue is the bronchial cuff. So most of the times we use a left-sided tube to isolate the lungs. So it has a short tracheal lumen designed to terminate above the carena, and the long bronchial lumen, distal portion of this lumen, has a freeform curve that allows the preferential entry into the bronchus, right or the left. Internal diameter of each tube is a D shape with the straight side of the D in the middle of the tube. So as I said, there are two inflatable balloons, bronchial and tracheal cuff. Because of the differences in bronchial anatomy between the two sides, tubes are designed specifically for either right or left bronchus. Adult DLT commonly comes in size of 35 to 41, and for younger patients, 26 to 32 French. So Hunsaker Monjet ventilation tubes, one more tube, is a laser resistant and designed for subglottic jet ventilation. Patient end has a basket shaped distal distension designed to center the tube. The outer diameter is 3 millimeter and has an integral lumen for monitoring airway pressure and the respiratory gases. This has been used to administer one lung ventilation also. And MLS or the microlaryngeal tubes with its long and big cuff to facilitate the microlaryngeal surgeries, available in 4 to 6 mm, each of which has the same length and cuff diameter as a standard 8 mm internal diameter tube. Designed for MLS surgeries or for patients whose airway has been narrowed as such extent that normal size tube cannot be inserted. The small diameter provides better surgical access, and the problems with this tube are incomplete exhalation and occlusion can occur. So other tubes are laser flex tubes. So laser flex tube is a flexible stainless steel tube with a smooth plastic surface and with a matte finish to reflect a laser beam, designed for use with the CO2 and KTP lasers. Cuffs are inflated by two separate inflation tubes. Distal cuff should be filled with first using until the sealing occurs. Then proximal cuff is filled with saline colored with the methylene blue. Distal cuff can be used if the proximal cuff is damaged by laser. Disadvantages are stiffness, roughness, and cannot be trimmed. And the double cuff adds to the time of intubation and the extubation. And some of the other tubes are intubating laryngeal mass tracheal tubes, designed to be inserted through the intubating LMA. Straight wire reinforced silicone tube with a tapered patient end with a blunt tip and short bevel and with a Murphy's eye can be autoclaved, used for submental intubation and tracheal resection and reconstruction of the tip has been removed. Easier to advance over a fiber scope, high pressure, low volume cuff available in size of 6 to 8. Coming to the size selection, guidelines for uncuffed tubes in the infants and children, though we are getting cuffed tubes in the children also now. For less than 1.5 kgs, the internal diameter is 2.5, 1.5 to full term, 3 mm ID, neonate to 6 months, 3.5, 0.5 to 1.5 years, 4 mm ID. For the cuffed tubes, less than 2 years, age by 4 plus 3, and greater than 2 years, age by 4 plus 3.5. For greater than 2 years, the size of the uncuffed tube is age by 4 plus 4 or 4.5. So coming out to the last slide, the sterilization. A tracheal tube or a double lumen tube is placed into an area of the body that is normally sterile. The tube should be kept in its package until just before use, and patient end should not be touched. So tube should not touch any part of the mouth or pharynx during insertion, and high percentage of tracheal or tubes show contamination with blood after use. If the tube is reusable, secretion should be prevented from drying. So by soaking in a detergent solution. After cleaning, thorough drying is important before chemical disinfection, gas sterilization. ETO is a popular method for sterilizing tracheal tubes. With repeated gas sterilization, rubber and plastic tracheal tubes soften and kink more easily. Spiral latex tube should not be gas sterilized in with a vacuum, as this can cause latex layers to separate. Steam sterilization has been used in the past for certain tracheal tubes. Repeated autoclaving makes them more likely to kink and cause a decrease in the elasticity of the cups. Spiral embedded tubes are usually susceptible to damage from autoclaving. Liquid chemical disinfection has been used for tracheal tubes. The inflating tube should be closed during the immersion to prevent the solution from entering the cuff. And the tube will frequently float and need to be held down with an object that does not distort it or prevent the solution from reaching all the surfaces. Thorough rinsing is necessary after use of all the chemical agents. And pseudomembranous laminitis has been linked to disinfection of tracheal tubes with butyrolide. Thank you. Any questions?
Thank you, Dr. Ravi. If there are any questions, please, you can unmute yourself and ask the questions, or you can go into the chat box and place your questions there. Any questions? If there are no questions, we'll go ahead. Thank you, Dr. Ravi, for the elaborate presentation on endotracheal tube. I know it is very difficult to cut short the endotracheal tube, the most essential thing in our armamentarium. We do not know where to start and where to end when it comes to endotracheal tubes. There are many and there are plenty. So you have done a good presentation, and I hope all the students present here and faculty will benefit by your presentation. Thank you. I see some question in the chat. I'll just go to the chat box. Okay. Olivia has written excellent talk. Abu Baker congratulated here. You can see that there's no questions there. Thank you, sir.
Yeah.
Coming to the end of NAES 11, we come to the point where we give our Thanksgiving. I welcome our additional professor, Dr. Nikhil MP, to give away the vote of thanks. Over to you, Nikhil.
Hello, ma'am. Can you hear me?
Yes, sir. We can hear you.
Yeah. A very good evening to all. It gives me an immense pleasure to propose vote of thanks on behalf of Department of Anesthesiology and Critical Care on the occasion of 11th Nitte Anaesthesia Education Series. We, the Department of Anesthesiology and Critical Care, are indebted to Nitte University for giving us an opportunity and support to hold such a scientific program, which is gaining popularity at a faster pace. A famous quote highlights, it's the teacher that makes the difference and not the classroom. So we all experience that today in the entire program. I may like to express our sincere thanks to Dr. Narendra Babu MC, Professor and Head of the Department, Kempegowda Institute of Medical Sciences, Bengaluru, for delivering today's masterclass on pathophysiology of chronic renal failure, who, sir, made it look very simple. Such a complex topic was made look simple here. We are thankful to you, sir, for accepting our invitation for this scientific extravaganza. I must mention our deep sense of appreciation to our moderators, Dr. Geeta CR, Professor and Head of the Department, MS Ramaya Medical College, Bengaluru, and Dr. Joylyn Stephanie D'Souza, Assistant Professor, K. Sedde Medical Academy, Nitte University, for their elaborate and comprehensible discussion on end-stage renal disease, which was posted for renal transplant today. Thank you, ma'am and Joylyn. I also wish to express my gratitude to Dr. Ravi M, Professor and Head of the Department, Sri Devaraj URS Medical College, Kolar, for giving an excellent coverage on various types of endotracheal tubes. Further, I also wish to extend my vote of thanks to the enthusiastic participants of the day, Dr. Varshini and Dr. Begum, who are junior residents from Amrita Institute of Medical Sciences, Kochi, for their enthusiastic participation and confident answering. Finally, I would take this opportunity to place on record our hearty thanks to the organizers, Dr. Shripad G. Mahendale and Dr. Sumalata Shetty, and the entire team for their tireless effort in making this program a successful one. Last but not the least, support staffs are key to the success of any program. And I thank the entire technical team for their dedication and hard work. Thank you, and one and all.
Thank you, Dr. Nikhil, for the vote of thanks. We close our NAES 11 now. We'll come back to you with our next preparation of NAES 12 in the month of July. Over to you, sir. Shripad, if you have to say anything.
Good evening again. We had a very good session starting from Dr. Narendra Babu, then Dr. Geeta and Dr. Joylin had a very good discussion on chronic renal failure patient coming for renal transplant. Then Dr. Ravi nicely put the various aspects of endotracheal tube in a very concise manner, beautifully presented. It was an excellent session today. I hope all the delegates enjoyed, and many of my friends and very senior faculty in anesthesia attended this session. It was a very heartening situation for all of us. Thank you for your encouragement and involvement. And especially my thanks goes to Dr. Begum and Dr. Varshini for the wonderful presentation. My colleagues, Dr. Gayatri Bhatt, Dr. Nikhil, for your MC, and vote of thanks, Dr. Gayatri Bhatt did a very good introduction as well. And I thank all my colleagues for the very active participation and support. I thank all the delegates, friends, faculty, and wish to see you on 21st of July again at 3 p.m. with our 12th episode, again probably on renal failure and similar topics. My good friend Dr. Abu Bakr is also there from Gulf. Thanks, Abu, for attending the event and encouraging. Thanks one and all. Wish you a good day and good times. Wish you all a very happy rainy season and very prosperous anesthesia. Thank you so much. See you. Bye.